There we go. All right. So if you're a patient, you are always interested in knowing, so you've come to your physician, and certainly one of the things you might want to know is, what's going to happen to me? Do I have pneumonia, which is potentially deadly, or do I have a head cold? And that's clearly an obvious thing to want to know. Because until recently, at least, hospitals have not operated on incentives that would encourage them to make patients better necessarily. They operate on what's called a fee-for-service model, in which case it's not always obvious that the financial incentive for the hospital is for the patient to get better, actually. The more services they provide, the more money they make, and so there's this sort of dichotomy, and certainly there's no one out there who is trying to make people sick in order to sell more services. But the incentive is there, and it's in the wrong direction. Recently, that's kind of started to turn around. So there are certain hospitals out there that now they're taking on risk. They're accepting a fixed amount of money for patients and accepting certain restrictions on how well they need to perform and how well their patients need to perform. And this is changing the incentives a little bit. So traditionally, rather than actually caring about what's happening to the patients in the entire hospital system, they kind of stick their head in the sand and say, well, we don't want to think about that because it gives us this sort of funny feeling. Now they really care. And so now we have this hospital systems that are actually interested in knowing on a broad level what's going to happen to their patient population, and on a specific level, what's going to happen to this patient, and how can we change that or modify that outcome. So we have this situation now where hospitals, their incentives are changing, their needs are changing, but they have a lot of data. They have a lot of information. And so I'm positioning myself, and Quintile's is positioning ourselves in the space between, where we can try and look at this data and answer useful, helpful questions for hospital systems or for other potential players in the healthcare space. For example, suppose you are wanting to run a clinical trial on diabetics. We need to know where those diabetics are. Or if you're a hospital, you need to know where your diabetics are, specifically the ones that are going to have bad outcomes, so that you can maybe target them for some other type of intervention or preventative intervention or something like that. So the data that we have, though, it's very messy and it's very complicated. So we have, there's continuous data like your age, maybe your blood pressure, lab results. There's text data, so the written notes of the physicians and the nurses, images, all sorts of other messy stuff in there. So in order to really address this, you need to be able to handle all of this data, and some of it is quite messy. So again, back to that diabetic example, if you're looking for those diabetic patients, you may find them by looking in the notes for the word diabetes. You might find them by looking in their medication lists for insulin or similar things. You might find them by looking in their labs and finding, say, a high glucose level or a high hemoglobin A1C. These are labs associated with diabetes. And any particular individual diabetic patient may be missing some of those or many of those. So the idea then is to pull information from all these different sort of complicated sources, understand what is related, and then identify groups of patients that are helpful, so that are interesting. So what we're trying to do then is exactly that. So I'm going to talk about a little piece of what we're doing, kind of in depth, and then put it in context sort of at the end. The approach that we're taking is sort of a patients like me approach. So I don't know if anyone has ever seen this website, Patients Like Me, but people go on and they maybe describe their diagnosis or describe their symptoms, and they find other people who are like them, and then they can talk about their disease, potentially join clinical trials as a group, these sorts of things. And it's actually very successful. We can do this in a sort of automated fashion by looking at electronic medical records if you have access to them. The model that we're using involves building separate models for each of the different types of data. And one of the models actually we heard about, or something very similar to it, 2 talks ago, dealing with plain text data. And I'll actually go into a little more in depth on the plain text data in a few minutes. But there are other models dealing with continuous data and categorical data. We put these together in a way that allows them each to inform on the other and build patient groups that are homogeneous. So if you can manage to build these homogeneous patient groups, then you can answer a lot of important questions. So let's say we have a group of patients of type X. Well, we know that certain medications work well for these people. We know their prognosis because some of them have been around for a while. We maybe know what treatments, what medications, just what's going to happen to them in general. Now, if you see a new person, and you can say with a high level of confidence they belong in that group, well, all of a sudden that tells you a lot about what this new person is, what's going to happen to this new person, and maybe what they need, and these sorts of things. The model that we're building, and this is where the math disappeared, so I'll just wave my hands a little bit. The model that we're building, it involves putting these patients together. I'm a Bayesian statistician, so there's a certain sort of clustering algorithm or clustering statistical model that we built in, and it incorporates a bunch of different data types, and it allows us to group these patients without learning a whole bunch of sort of unimportant, uninteresting parameters about them. We just say, all right, here's the group, there's another group, there's another group. And it's kind of neat because you can now start to bring in other types of data. So for example, if you've been watching the news, you know that CVS has decided to stop selling cigarettes because they're going to start opening clinics in their stores. And Target, the big superstore, Target, also is starting to open clinics in their stores. Now, if I know about certain patient groups and I'm CVS, then I can start to ask, all right, I've learned about these patient groups from some other source, say an electronic medical record from a willing hospital or some sort of collaborator. I have these patient groups, and I know about their medications, and now I can go and look at the medications that my customers are buying and start to think about what types of people are coming into my stores. Not only that, I can attach to that the other things that they buy and start to understand on a broader scale who these people are and what's going to happen to them, and maybe identify new products that I want to develop for those patient populations. Let's see. Okay, yeah, messy data, right? So there's a challenge here. Hospital data has only just recently decided, there's a new mandate that they build electronic medical records. And up until now, many of them just haven't been doing it. Many of them have been doing it in a very piecemeal way. I know of one hospital system, for example, they had electronic medical records, but it was a totally different system for every department. So your emergency department had its own medical record, and your internal medicine group had its medical record. They didn't really speak to each other. So, if the internist wanted to know what happened in the ER, it wasn't always easy. So these things are very complicated. Also, there's no copy editing here, as you can see, right? So if we pull out, say, physician notes, and we want to find patterns in these notes to identify groups of patients that are relevant for one reason or another, there are challenges. So there's an approach to dealing with plain text called natural language processing. And I want to put just a brief bit in here. Whenever you hear someone say that they've taught their computer to read, typically what it means is they're doing some sort of natural language processing. And there are ways around this, but the standard approach, and the approach taken in medicine, is to write down everything that you can think of that would be important. So a whole list of synonyms, a whole list of what are called concepts. So the flu might be a concept and have a whole bunch of synonyms. A whole tree that would describe, say, a person is a primate is a mammal, these sorts of things. So they build this thing out. You can see it becomes huge. It's a distributed approach to dealing with this. So you'll have groups all over the place building their own lexicons, their own dictionaries. And it's come together sort of piecemeal. And as you can see, if you type 60 words a minute, it takes 7 years of nonstop typing to generate this much data. It has all kinds of problems and all kinds of challenges because there's so many arbitrary decisions that have been made. I actually have, for longer talks, have 10 or 11 slides that I like to show that gives really sort of more details. And I always challenge myself to find the first person to yawn during that part of my talk and then skip past. I have not yet made it past slide 2 or 3. So anyway, it's not that interesting or exciting, but people do it. And I'll show you some sort of successes and failures of this approach in a slide or two. Okay, I'm going to do I'll show you a case study, and before I do that, I want to show you what data is associated with this case study. So this is electronic medical records data from an emergency department. There are about 54,000 records. It's the first 3 quarters of 2009. And we're going to analyze this data. It's going to have 4 different dictionaries, 4 different documents, plain text written documents, with all of them have their own typos and mistakes and errors and these sorts of things. Have a bunch of different categorical data, a bunch of different continuous data. We want to put these things together to identify homogeneous groups of patients. Before I do that, so let me show you the MetaMap example that I was talking about earlier. So this is the natural language processing. I've taught my computer to read kind of example. So using the data that I just described, this is just one note from one nurse's note from one patient. And I'll just read, so each 1, 2, 3, 4, 5, 6 on the left are sentences from that note, and they're in there consecutively. And then 1, 2, 3, 4, 5, 6 on the right are the translated with natural language processing concepts that come out of this note. So on the left it says, patient here complains of, that's CO, nausea and vomiting, that's NV, and shakes. And the shakes is in quotes because it was in quotes in the note. Decreased taking by mouth, so they've been eating less for the past 2 days. The patient has a pain pump. Patient is now taking PO narcotics, and then it says they're vomiting, so they take their medicine, it comes back up. And then they have chronic back and neck pain. So that's a certain type of patient. Now, I want to read on the right, number 1 turns into a tremor, and you can see where that came from. The word shakes turned into tremor. That makes some sense. Number 2, it captures very well. Number 3, pain pump. That's right. That's good. 4 is fine. Number 5 caught the letter N in nausea and vomiting, and decided that was a grade for a tumor type, N+. So it captures a tumor. And then chronic pain is there as well. So on the left, you see someone who's just got sick and they're vomiting. On the right, you see somebody with tremors, and you see someone who's cancer. Maybe they have a new metastasis in their brain that's causing tremors, right? So it's right in a lot of ways, but it's so very wrong. So there are lots of ways to succeed and fail in this sort of thing. And so that's my plug. I have to talk about it because it's really the default approach for analyzing electronic medical records, plain text in electronic medical records. Okay, so a messy graph, the antithesis perhaps of the last speaker's presentation, but I'll try and do my best to make it not, make you not think there's something there, but I just don't understand what it is. So let me describe what's going on. So we have these groups of patients. And the groups of patients are across the bottom. And I've labeled number 45 because the 45th group, is the one that I'm interested in for this particular picture. And on the y-axis, I've labeled, I've shown the labels. These are words that show up in the diagnosis, okay? And you might be confused because there are spaces there, right? So the third one says chest pain acute. I'm treating that as a single word in this particular case. And there's nothing in the statistics or modeling that requires that you treat a sequence of letters separated by spaces as a word. You can include phrases or whatever you like. Okay, so what we're seeing here is we've run this model, we've included all these different types of data, and we've got groups of patients that are hopefully homogeneous. And it does some really cool stuff. Like, for example, it finds coronary artery disease as the second, CAD, sorry, is the second one down, and coronary artery disease on the bottom. And these are synonyms. They mean the same thing. But I haven't taught the computer that. I'm not using natural language processing to tell it that. It's just finding that. And it's finding that because these things show up with other things that this group of patients has. For example, aspirin, or maybe cardiac markers have been ordered, or these sorts of things, or other types of pain scores. So on the coloring that you see here, blue means unimportant. Sorry, that's really special. Red means a strong association with this group, right? It's the log odds ratio if you're really curious. But so you can see that all these words are highly associated with group 45. And if you look in the rest of the picture, there's a lot of blue. Now there are individual cases where single words show up in other groups as well. For example, chest pain other, if you look over far on the right, you see the little orange line. It's showing up in some other group. It's relevant somehow in that other group as well. But what's important here is the combination of things. So when you have a messy data set, a complicated data set, and you want to identify patients because you want to learn about what's going to happen to them or because for whatever other reason, you have to deal with the fact that things are going to be missing, things are going to be unrecorded, sometimes synonyms will be there, sometimes misspellings, all these things have to be there. So you have to work with that. All right, so I'm going to zoom out and show you the other things in this diagnosis group. So the diagnosis in the top middle is the exact same figure I just showed you, but you can see there are a lot of other things going on here. So we have nurse's notes, top left, medications, top right, orders in the bottom left. And for example, there are synonyms in all of these things. For example, ASA and aspirin are both listed in that medications list. Those are both aspirin because patients with heart disease take aspirin. Aspirin is not causing this, although there may be some other cases, and I'll talk about that in a second. You can see also that age is important in this group. So the bottom right corner, what I'm showing you there are two different distributions. So if you've seen histograms, that's what this is. The blue shows you the base distribution of patients in this hospital system. There is some little spike for newborns. Mostly they have a children's ER, so mostly children's age people do not show up. And then you see these middle-aged folks. That's the blue. The red shows you the ages of the people in this group. So you can see this is a disease of the middle age, of 50 years old, plus or minus a little bit. Not surprising, I'm sure. If you have preconceived notions about what heart disease looks like, that fits the bill. All right, so this model that we have, it deals with this messy data. We're allowed to bring in all sorts of different types of data. It deals with misspellings and typos, and it identifies synonyms and brings them in together. So it really has some very nice features for dealing with the sorts of data that we find in medical records. This is another example just to show you that to show you that the text does not have to be critical for the identification. So in this case, we're using just demographics, so age and temperature and these sorts of things. So you can see the spike at age. These are all very young patients. You can see a very high pulse, a very high respiratory rate, no systolic and diastolic pressures measured at all. Sorry, I'm going to cough again. And the temperature that's very high. And this is sort of a classic constellation of symptoms that go along with febrile seizures. These are fairly common and not that terrible, but it's kind of cool that the model picks it out and identifies it as a very specific type of diagnosis that shows up in this patient group. That's not what I meant to do. All right, so what can you do with this? There are actually lots and lots of things you can do with this. And I'll show you even more when you put it in context. So when I say, and I guess I'll get to that in a sec, but so one of the easy things to do with medical records is what's called pharmacovigilance. It just means look for side effects, look for drug side effects. And this is something that pharma companies are required to do for drugs in what's called phase 4. You have to keep track of what's happening once your drug is out there and make sure that it's not causing heart attacks like Vioxx, for example. All right, so we can look in these patient groups, and this happens to be a diabetes patient subpopulation, and we can look at the medications they're taking and ask, all right, well, what are these things? So, of course, many of them are drugs for diabetes, and that's what a lot of these things are. Novolog, for example, is an insulin analog. But there are other things in here that might actually be causing problems. So, for example, it's kind of well known that the schizophrenia drugs, and clozapine in particular, can cause diabetes. So this is probably a direct cause. Diuretics, when you flush out water out of your system, you're left with whatever else is there, and sometimes that throws off the balance of sugar to water in your blood, and so that can actually make controlling your diabetes really difficult. So that's potentially why that's showing up there. And you have some other things in here. Namenda is a drug that you would take for dementia, and it's maybe possible that demented patients have trouble just managing their drugs. And so that may be showing up not because it's causing diabetes, but because it's a drug that is taken by people who just have trouble controlling their diabetes. There are some other kind of cool relationships that show up between drugs and patient groups, and I'll just highlight a couple. Sometimes they're really simple, like if you get bitten, you might take Tylenol because it hurts. So Tylenol and rabies tend to show up together. Tylenol is probably not causing rabies, most likely. There's another one here, Casodex and sickle cell disease. And I found this and I thought, well, that's really weird because Casodex is a chemotherapeutic. It's something you would take for cancer. And so it doesn't make any sense, but I managed to find just a couple of papers, really actually just one paper, which had anecdotal evidence of a sickle cell patient who was a male who had priapism, taking this drug and having the priapism go away. So priapism means you cannot get rid of your erection, in case anyone's curious. And so this is a really scary thing for sickle cell patients. And so I went back and looked, and it turned out everyone taking Casodex in the data set who had sickle cell, they were all men, so not surprising. So I think that's what's going on there. We've discovered an off-label use for Casodex that hadn't been well known. The last one I think is kind of interesting is this drug, buspirone, which is an anxiolytic. That means it makes you less anxious. And perhaps these folks just should have been a little more anxious around, say, the growling dog or the scratching cat. So there are all kinds of reasons why these things show up, and they're all really interesting, or many of them are really interesting. Okay. Let's see, where are we? Okay, so I want to show some other examples. Okay, I'm going to skip the example. So we have some examples of showing how this model performs in identifying relationships between drugs and patient groups, and comparison to other ways of identifying relationships between drugs and patient groups. And what we did was we fit the model and we learned these relationships, and then we tested them out on a new data set. And it turns out that the relationships we identify between our homogeneous patient groups and drugs are much more likely to reproduce than in other approaches to doing this sort of thing. Similarly, you can do this with differential diagnosis. So let's say someone comes in and we want to use the nurse's note and only things that we can learn before the doctor ever sees the patient to try and predict what's wrong with these patients before the doctor sees them. And it turns out you can do a very good job of that with this approach. So we have this group of patients, we have a certain collection of things that we learn before the physician shows up, and we use that to assign them to a group, and then we look at that group and figure out, all right, what was wrong with that group? And it turns out you can do a very good job of identifying patients, differential diagnosis with that approach. Okay, so I'm going to go back to the CVS example or the Target Superstore example where you have your clinic and or maybe even just an urgent care center, and you want to offer a very specific set of services, and you have to think about what those services should be. This is a very nice way of identifying groups of patients that you might target if you're willing to do certain things. For example, here's a group of patients that have abscesses, and you can see they're all abscesses. And I'll just remind you, each of these is a separate word in the dictionary, and I didn't train the model beforehand to say, if you see the word abscess, put it together. This was put together because these folks have other things that are very similar. All right, so 1.3% of patients in this ED record have fall into this category. So if you're CVS, maybe you want to treat these folks, maybe not. You have to decide. There's a little procedure potentially that you might need to use. You have to cut open the abscess and squeeze out well, whatever. So anyway, there's stuff you have to do or think about if you want to bring these groups on. And there are other things too, same sort of idea where you want to potentially pull in other patients. You need to know how many patients are there like that, what are the things we might need to do for them, and how expensive and how much do we stand to earn from that sort of an approach. Along the same lines, if you want to identify the patients that are in your store specifically, you might want to know, all right, are there relationships between drugs and diseases, and we can find those. I'm going to skip ahead to this slide. This is our last slide. All right, so I have this group, this way of bringing patients together, this way of describing a patient's disease based on what they're showing at the time that they're in your clinic. But that's just one snapshot of this patient, and there's actually a whole trajectory of health and unhealth for everybody. And you would like to know or like to be able to decide if you can predict what's coming in the future for lots of reasons. One reason that hits home at Quintiles, we're a clinical research organization. It means one of the things that we are charged with doing is finding patients for clinical trials. And if a drug company wants to, in this case, test out a drug for Alzheimer's that only really works if you catch them early. So it's something that sort of slows the disease down or halts the disease but doesn't heal. Then you need to catch people before they have Alzheimer's disease. And that's really very difficult from the medical record. But if we look at patients who have Alzheimer's disease and we put the model that I just described in context, we can track what happens to them through the course of time and find, for example, what happened to them 2 years ago, and is there anything in there that's predictive that tells us these are the people who are going to have Alzheimer's disease. So this is a sort of a trajectory of what happens with someone who has Alzheimer's disease, and if you look, a couple of years, maybe even 3 years before they're actually diagnosed with Alzheimer's disease, a fairly large percentage of them start having dental problems, meaning they have aggressive dental caries or they have to have a tooth pulled or whatever else. And this jives very nicely with what caregivers often say, which is the first thing we noticed about Dad was he stopped shaving, and he always shaved every day, and now he's got a stubble in it. So this sort of loss of personal hygiene, this is known to be one of the first things that sort of start disappearing. And if you can find things like that predict, okay, this is your patient population. These are the folks you want to go to for your new trial or whatever. Or if you're a hospital system, these are the folks you want to go to offer preventative care. Or maybe you want to take these folks and say, all right, we need you guys to start doing memory exercises or whatever. And that's actually been shown to be fairly effective, more so than any other drugs. That's how you do it. All right, so this is where we are. And our general theme is to identify diseases and track and predict what's going to happen to patients for many different players in the healthcare system, for physicians and patients and hospital systems and ourselves and pharma companies. If there are questions, I'm happy to take them.
We have time for one question. That's a burning question. Okay, I think we're all just hoping they're not Alzheimer's.
Yeah, okay.